this month's nursing training program. Today we will be going to discuss about the bleeding disorders in children. So for this we have with us Dr. Meena Sivsankaran. She is a senior consultant in Department of Pediatric Hemato-Oncology at Kanchi Kamakoti Child Trust Hospital, Chennai. And Mrs. Princess Margaret, she is nurse manager at KKCTH, Chennai. So they'll be briefly discussing about the overview of the bleeding disorders and how to manage them using blood products and various factors. So over to you, Meena.
Good evening, everyone. Myself and Mrs. Princess Margaret today will be discussing about the bleeding disorders with nursing perspective. Initially, we'll be giving overview of about what is primary hemostasis and secondary hemostasis, what are the major bleeding disorders, and broad management principles. And because most of the children, if they come with bleeding, they'll need blood product support, either the platelet transfusions, FFP, or cryo if there is a massive bleeding, sometimes PRBC also. So how to administer the blood component and the factor concentrates when in need, and what are the common family educations we need to give. So before going into the bleeding disorders, there is how hemostasis occurs in our body. There are three steps: primary hemostasis, secondary, and then tertiary hemostasis. What is primary hemostasis? Whenever there is an injury, in that place is platelet comes and act. So first step is platelet adhesion, followed by platelet aggregation and formation of the platelet plug, which help in formations of the initial platelet plug formations. Once this platelet plug is formed, next here comes our clotting proteins. We have 13 clotting proteins in our body. Comes and forms a fibrin mesh. So in factor 13 will help in stabilization of these clotting factors. So once a platelet plug is formed, all our clotting proteins comes and act and help in formation of the fibrin formation. Once this is formed, then the next step happen is the fibrinol. Then the next step what happens? Sorry. The next step, what happens is the fibrinolysis. Fibrinolysis will help in reducing the excess formation of the clot. So once these three steps happen, there is an adequate hemostasis is achieved. If there is defect in these hemostasis, child can present with excess bleeding or clot. Primary hemostasis involves the blood vessels, platelet. If there is low platelet or if the platelet is not functioning properly, as there is an thrombasthenias, they can present with skin and mucosal bleed. That is mainly they can present with petechiae purpura in the skin, or they can present with the bleeding in the nose or in the mouth. If there is a defect in the secondary hemostasis, mainly the clotting protein defect, made common as a factor 8 deficiency, followed by factor 9 and von Willebrand defect. If the problems with this, they can present with the deep bleed like muscle bleed or the joint bleed. Von Willebrand disease can present with both deep bleeds as well as the cutaneous bleed. These are the common two types of bleeding. So if there is a defect in the primary hemostasis, they can present with skin bleed, petechiae, purpura, subconjunctival hemorrhage, ecchymosis, nosebleed, or mouth bleed. If there is a defect in the secondary hemostasis, that is a disorders of the clotting proteins, they can present with joint bleed and then muscle bleed. Whenever we come across child with bleeding disorders, we will screen for whether that platelet number is normal or whether their clotting proteins are normal. To screen this, we have to look at the complete blood count, which to look for the number of the platelet. As well as we need to check for the hemoglobin, whether there is excess bleed and then dropping hemoglobin. Next is though the bleeding time is absolute, still it can be used in the children as a bedtime to assess the functions of the platelet. If there is a platelet number is low or if the platelet is dysfunctions, bleeding time will be prolonged. Prothrombin time and activated partial prothrombin time. We have seen the secondary hemostasis where we have 13 type of clotting proteins. These functions in form of intrinsic pathway and then extrinsic pathway. If there is a defect in this pathway, PT and APTT will be prolonged. Whether the only isolated prolongation of PT or whether the isolated prolongation of APTT or the combination of the both will help in identifying the underlying bleeding disorder. In some cases, we can have in coagulopathy, DAC, sepsis, we can have low fibrinogen level or inherited forms of fibrinogen deficiency. So thrombin time would help in identifying the if in case of if there is a fibrinogen deficiency. If our platelet count is normal, if a bleeding time is normal, our PT, APTT is normal, even then there might be a possibility for the underlying bleeding disorder. In factor 13 deficiency, platelet number and PT-APTT will be normal. Clot stability won't be proper. So there is the unstable clot. So factor 13 screen would help in identifying the factor 13 deficiency. These are the screening tests we need to look for when we are dealing with the bleeding disorder. As a nurse, what you have to do when you're sending the sample, because sending the correct sample is important. If there is a clot in the EDTA sample, will show the platelet count falsely low. So when we are collecting the sample, there should not be any clot. At the same time, when we are collecting the sample for the PT-APTT in the citrate tube, need to avoid squeezing of the limb or applying the prolonged tourniquet and avoid sampling from the heparinase line or the heparinase ridge. If you're taking from the central line, always do the take the discard tube first, then collect the sample for the analysis. When we are collecting the sample, it needs to be in a ratio of 9:1. That is a 9 part of blood and 1 part is anticoagulant. This ratios needs to be maintained. In each container, there will be a mark up to which we have to take. If it's underfilling or the overfilling of the tubes can result in abnormal coagulations results. So taking the correct sample is important. Otherwise, we'll end up in getting the wrong values, which will lead on to the unnecessary product administrations or delay in the diagnosis. So always sending the correct sample is important. So always whenever we are dealing with the child with bleeding disorders, look at the platelet count. If platelet count is low, we need to evaluate for the process of thrombocytopenia. If platelet count is normal, need to look for the platelet function defect, either the von Willebrand disease or Glanzmann thrombasthenia. Next is if you're thinking in terms of deep bleed or joint bleed, thinking in terms of problems with the coagulation proteins defect, whether there is an isolated prolongation of PT alone, it might be due to the liver disease or factor 7 deficiency. If the isolated prolongation of the APTT, it's an intrinsic pathway clotting proteins defect that is commonly the factor 8 and 9. If both are prolonged, commonly due to the DAC, sepsis component, and common pathway factor is a factor 10 and 5 defect. So based on this, we'll classify what is the baby's underlying bleeding problem. So now I'm going to discuss only covering about the inherited bleeding disorders, not discussing about the sepsis or DAC component. If they have underlying factor 8 and 9 deficiency, they have isolated prolongation of the APTT, more prone for the muscle bleeds and then joint bleed. Need to, in case if they are presenting with the bleeding manifestations, we can give specific factor concentrate. If you're dealing with the number of the platelet count is low, they present with the skin and mucosal bleed. If there is a significant bleed, we need to consider platelet transfusion. If the plate qualitative defect, if there is platelet function is not normal, again they'll present with the skin and mucosal bleed. Even though your platelet number is normal, the platelet is not functioning properly. So apart from antifibrinolytic, we need to consider platelet transfusion. In von Willebrand disease, they can present with both deep bleeds and skin and mucosal bleeds. Here, similarly, like factor 8 concentrate, there are the factors which has a von Willebrand as well as the factor 8 is available. We need to consider factor replacement therapy. So when we come across the child with bleeding, what are the broad management, what we should advise for those kids and then parents? Always we need to avoid drugs which is going to cause increase in the bleeding like NSAIDs, aspirin, ibuprofen, and avoid unnecessary intramuscular injections. In case if they need any vaccinations, need to use the smallest gauge needle possible, and after giving the injections need to give compressions for few minutes to reduce the bleeding. If there is any injury, we have to act immediately, and based on the type and then severity of the injury, need to replace them with the clotting factors like football, cricket, those type of contact sports we can avoid, but we can encourage the activities like cycling, swimming, but need to ask them to avoid contact sport. Whenever we come across a bleeding child, always check their blood group and then issue what is their blood group and what products in case if they land up in the emergency, because factor concentrate won't be available in all the hospitals at always. So in case of if there is any significant bleeding, if they go to the ER, what is the first step we need to give? For example, if the child with hemophilia can present with severe bleeding, factor concentrates are not available, so they can first initially we can administer cryoprecipitate. So what is the precautions we need to give, that we need to advise, because factor concentrates multiple repeated blood products, they are more prone for transfusion transmitted infections. So vaccinations against hepatitis B is important. And this is a polar strategy which we need to follow in case of any injury. So first is the protection of the injured site is important. This is the previously we used RISE term. Now it is changed into POLIS. RISE is the rest, and then ice compressions, and then elevation. Here, POLIS is P for protection. Protect the area of the injury is the first. Then it's optimal loading. Previously, we have to give rest as much as possible. Now they are moving from the rest to start with the weight bearing as early as possible, so that it will prevent the long-term complications. Next, apply the cold compression and elevation of the limb. Immobilize the joint during the bleeding. As soon as it's settled, it start the progressive exercise to improve the mobility. And broad management principle, in case if they're presenting with mild mucosal bleed, we can consider antifibrinolytic therapy, tranexamic acid at a dose of 15 mg per kg, either the oral or intravenous, based on the severity of the bleed. And in case if they have low platelet count, or if the platelet dysfunction is the underlying problem, need to consider platelet transfusion. If you have identified the problem, if it is a factor 8 deficiency, need to consider cryo. If it is a von Willebrand, need to consider cryo. Fibrinogen deficiency, need to consider cryo. If you don't know what is the underlying problem, prolongation of the PT, APTT, better consider FFP transfusions, because FFP will have all the clotting factors. If we have the diagnosis with them, need to consider factor replacement therapy based on the underlying bleeding disorders. And recombinant factor 7 can work in any type of bleeding disorder in case if there is a life-threatening bleeding, it's not able to control the initial management. These are the broad management principle of bleeding disorders. Next, our nurse, Mrs. Princess Margaret, will take us through the blood product support as well as the administration of the clotting factor concentrate administration.
Good evening all. Now we are going to see about infusion therapy in bleeding disorders. Infusion therapy in bleeding disorders, we have blood products administration and clotting factor concentrate administration. For administration of blood products and clotting factor replacement, we need a very good lines. So we have to secure the IV line for the bleeding children. Mainly the IV lines are lifelines for the pediatric patients. So we should handle it very carefully. We have to use 23 to 25 gauge Venflon. Apply firm pressure on for 3 to 5 minutes after venipuncture. Safety check prior and during administration of blood products, we can see now.
Shivani, slides are moving up. Not able to.
No. Change the slide again.
I'll share the slide again. Now it is moving, no?
Yeah.
Now we will see the safety check prior and during administration of blood products. First, in step 1, we should check the patient name, blood group, indication for transfusion, required products, and the volume of transfusion. In step 2, we should check for blood group of bag provided, bag number, collection date and expiry, and compatibility label to prevent the transfusion reaction. In step 3, we should check for any leakage or discoloration of or clot presence in the blood bag. In this slide, we can see about what are all the in which case we can transfuse the products, or when we cannot transfuse the product. In some degree of hemolysis can acceptable. We should check the platelets full under the against the light. If the platelets presence means we can administer the platelet transplatelet for and transfuse the platelet. Minimal red cell contamination also allowed. If there is a visible clots or fibrin strand seen means we should not transfuse the platelet. Cellular aggregates and cold agglutinants present means also we cannot transfuse the platelet. If bacterial contamination presents also, we cannot administer the platelet. Here we can see the hemolysis in this slide. You can see the cloudy, that hemolysis occurs means we cannot transfuse the platelets. In step 4, initiate and monitoring transfusion. During transfusion, we should monitor the patient while giving platelet transfusion, platelet or blood product transfusions. First, we should check the patient general appearance, temperature, pulse, blood pressure, respiratory rate, and fluid balance. We should maintain the IV fluid, IV intake output chart also. Time points before starting the transfusion, as soon as after the transfusion is started, and after 15 minutes after starting the transfusion, at least every hour during transfusion, and last on completion of the transfusion, and 4 hours after completing the transfusion. Step 5, record the following. Blood recording is the important aspect in while giving blood transfusion, because this is the anytime allergic reactions can occur. So we should monitor the patient vital signs and we should record it promptly. Time the transfusion is started, time the transfusion is completed, volume and time of all products transfused, unique donation numbers of all products transfused. If any adverse effects occurs means we should immediately inform the doctors and activate the emergency system. Blood component administration. PRBC, platelet, and fresh frozen plasma cryoprecipitate we are giving in the blood components as blood components must be administered through the standard blood transfusion set, that is 170 to 200 micron filter set. This is a standard set we are using. The time limits for infusion. There is a risk of bacterial proliferation or loss of function in blood products once they have been removed from the correct storage conditions. We should we should administer the or transfuse the products according to the chart. In this chart, we can see the components. For PRBC, we should start the transfusion within 30 minutes of removing from the refrigerator. It should be completed within 4 hours. It should not be beyond 4 hours. For platelet concentrate, immediately we should transfuse the platelet concentrate after receiving from the blood bank. And it should be completed within 30 minutes. For cryoprecipitate, as soon as possible after removing from fridge within 6 hours of thawing, and it should be completed within 30 minutes. For FFP, as soon as possible after removing from the refrigerator, and that also within 6 hours of thawing, within that also completed within 1 hour of within 1 hour. Next slide, platelet product. In this slide, we can see about platelet products, dose and administration. Platelet concentrate must be ABO and RH compatible in order to prevent reactions. The usual recommended dose of RDP is 1 unit per 10 kg body weight. SDP is 10 to 15 ml per kg, that is below 30 kg of unit SDP, and above 30 kg 1 unit SDP. Transfuse platelet over 30 minutes. The recommended rate of infusion is 10 to 20 ml per kg per hour. Do not fresh frozen. Next, we will see about fresh frozen plasma and dosage and administration. In fresh frozen plasma, it contains all the coagulation factors. It should be ABO compatible. Transfusion volume is 15 to 20 ml per kg. Repeated doses may be required to correct a clinically significant coagulopathy. Infuse as soon as possible after thawing, and in any case, use within 6 hours of thawing. Labile coagulation factors rapidly degrade. Infuse at a rate of 10 to 20 ml per kg per hour. Next, we see about cryoprecipitate product dose and administration. Use ABO compatible product 5 to 10 ml per kg at a rate of 10 to 20 ml per kg per hour. Must be used within 6 hours of thawing. Each unit has approximately 25 ml. Each unit of cryoprecipitate contains about 80 units of factor 8 and Van Willebrand factor, 150 mg of fibrinogen, and varying amount of factor 8. Factor 13, sorry. Next, we'll see about ABO selection for platelets and plasma products. The recipient, if the recipient is O group, means choice of blood group is first choice is O and the second choice is A. Third choice is B group platelet and plasma. Fourth choice is AB group platelet and plasma. For recipient is A group means we can administer first choice A group platelet and plasma, AB group platelet and plasma. For B group recipient, we can administer B group first choice B group platelet and plasma. Second choice is AB group platelet and plasma. For AB positive group recipient, we can administer AB as a only choice. AB group, the same group, we can administer the platelets. In next slide, we can see acute transfusion reactions. While giving blood transfusion, we should monitor the patient for reactions. The transfusion reactions is two types, immunologic and non-immunologic. In immunologic, we will have acute hemolytic transfusion reaction, transfusion-associated lung injury, severe allergic reaction, and febrile non-hemolytic transfusion reaction. In immunologic, in immunologic transfusion-associated lung injury, we will have the bronchospasm. We should immediately resuscitate the patient, and we should escalate for further management. Non-immunologic reactions are infusion of a bacterially contaminated unit, volume overload, hypothermia, and electrolyte disturbances. In this next slide, we can see about the allergic reactions. Three categories, that is mild, moderate, and life-threatening. First category is mild. The patient will have the signs of localized cutaneous reactions, urticaria, and rashes. Symptoms: patient will have pruritus, possible cause hypersensitivity. Second is moderate. The signs are flushing, urticaria, rigors, fever, restlessness, and tachycardia. Patient will have the symptoms of anxiety, pruritus, palpitations, and mild dyspnea and headache. Possible causes are hypersensitivity, febrile non-hemolytic reactions, contamination with bacteria or pyrogens. Third is life-threatening or severe allergic reactions. That is, the signs are hypotension, tachycardia, hemoglobinuria, and unexplained disseminated intravascular coagulopathy. The patient will have the symptoms of chest pain near infusion site, respiratory distress, backache, headache, and dyspnea. Possible causes are acute intravascular hemolysis, fluid overload, bacterial contamination, anaphylaxis, or transfusion-associated lung injury. We'll see about the immediate management for each category. First, category 1, for mild transfusion reaction, slow the transfusion, administer antihistamine as IM. If no clinical improvement within 30 minutes, or if signs and symptoms worsen, treat as category 2. Category 2 is moderately severe. For moderately severe, we should stop the transfusion, replace the infusion set, and keep IV line open with normal saline. Notify the doctor and inform the blood bank also. Send the blood unit with infusion site and freshly collected urine and new blood samples. That is one clotted and one anticoagulated sample from vein opposite to the infusion site with appropriate request form to blood bank and the laboratory for investigations. Then administer antihistamine as IM and oral or rectal antipyretic. If a fever present means we should administer paracetamol 10 ml per kg, 10 mg per kg, 500 to 1 gram in adults. Avoid aspirin in thrombocytopenic patients. Give IV corticosteroids and bronchodilators if there are anaphylactoid features, that is bronchospasm or stridor. Collect urine for next 24 hours for evidence of hemolysis and send to laboratory. If clinical improvement is there, restart the infusion slowly with the new blood unit and observe the patient carefully. If no clinical improvement within 15 minutes, or if signs and symptoms worsen, treat as category 3. Category 3 is life-threatening. There is severe allergic reaction. Immediately we should stop the transfusion, replace the infusion set, and keep the IV line open with normal saline. Infuse normal saline to maintain systolic blood pressure. If hypotensive, give over 5 minutes and elevate patient's legs. Maintain airway and give high flow oxygen by mask. If saturation is fall below 90%, give adrenaline 1 in 1,000 dilution. Then as intramuscular, give corticosteroids and bronchodilators if there are anaphylactic features. Give diuretic, example furosemide. Notify the doctors and responsible and inform the blood bank immediately. Send the blood unit with the infusion set, fresh urine sample and new blood samples. As previously said, one clotted and one anticoagulated sample from vein, and with appropriate request form. Check fresh urine specimen visually for signs of hemoglobinuria. Start a 24-hour urine collection and fluid balance chart and record all intake and output. Maintain fluid balance. Assess for bleeding from puncture sites or wounds. If there is clinical or laboratory evidence of disseminated intravascular coagulopathy, give platelets, either cryoprecipitate or fresh frozen plasma. Reassess if hypotensive. Give further saline 20 to 30 ml per kg over 5 minutes. Give inodrops if needed. If urine output falling or acute renal failure means raising potassium or creatinine, urea and creatinine. Maintain fluid balance accurately. Give further furosemide. Consider dopamine infusion if needed. Seek expert help. If bacteremia, we should start immediately broad spectrum antibiotics and cover the Pseudomonas and gram-positive organisms to cover. Next, we will move to the hemophilia A, which needs factor VIII replacement. Recombinant factor VIII or plasma-derived factor VIII concentrate we are using for hemophilia A. Each 1 international units per kg raises factor VIII level by 2%. Half-life is 8 to 12 hours, so we have to give twice daily dose. Formula for dose calculation is dose is equal to weight in kg into desired percentage of rice into 0.5. Mild to moderate bleed 25 units per kg. Severe or life-threatening major bleed occurs means we should give 50 international units per kg. For major surgery, we should give 50 to 100 international units per kg based on target level. For continuous factor VIII infusion, for if major surgery for the patient, we should loading dose 50 international unit per kg, maintenance 4 to 5 international unit per kg per hour, requires close monitoring. In hemophilia B needs factor IX replacement. Factor IX replacement, plasma derived or recombinant factor VIII concentrate we should give. Each 1 international unit per kg raises factor IX level by 1%. Half-life is 18 to 24 hours, so we can give once a daily dose. Higher doses required for recombinant factor IX. Formula for dose calculation is dose is equal to weight in kg into desired percentage rise. Moderate bleed means 50 units per kg and life-threatening bleed 100 units per kg. For next, we'll see about von Willebrand disease, deficiency or dysfunction of von Willebrand factor. Common symptoms: mucosal bleeding and menorrhagia, may have secondary reduction in factor VIII. Dose formula for dose calculation: dose in international unit is equal to weight in kg into desired percentage rise. We can give twice daily. Monitor the patient for reactions. Then factor concentrate, how to dilute the factor VIII. We'll see about the dilution. For dilute the factor concentrate, bring the vial to room temperature by gently rolling between the hands. Add the diluent. Mix by gently rolling the vial. IV bolus or infusion over 15 minutes we can give 3 ml per minute and use the full vial. Next, we will see antifibrinolytic therapy. In antifibrinolytic therapy, we are using tranexamic acid 15 mg per kg orally or intravenous every 8 hours. We avoid in renal bleeding patients. Next, we will see about family education. For family education, we should educate the parents to avoid worsening of the condition. Early recognition is life-saving. Identify early signs of bleeding. Skin or mucous membranes. Inspect the skin or mucous membranes for petechiae, purpura, or epistaxis. Often indicate platelet issues. Deep bleeds, painful. Deep bleeds will painfully swollen joints or muscle hematoma suggest coagulation deficiencies like hemophilia. Head and neck or face injury is an emergency. Never delay factor infusions. Safe environment. Encourage age-appropriate safety like padding knees for crawling infant or using helmets for active toddlers. Uh, Family education, avoid risk activities, advise against contact sports in favor of lower impact options like swimming or cycling. Teach police strategy, as earlier madam told, police we should follow the police strategy to avoid the worsening of the condition. Home and school, provide care plan to be followed at home and in school in case of bleeding. Multidisciplinary team follow up to recovery for the early recovery.
Thank you. To summarize, bleeding disorders in children is not rare. In day-to-day, not only are inherited bleeding disorders, all our hemato-oncology patients, they present with repeated low platelets count. All our transplant patients will have low platelets or significant bleeding. So the broad management principles for bleeding disorders is same. So whenever we come across child with bleeding disorders, what is the type of bleed the child come to us? First, we need to see if there is a skin and mucosal bleed, that indicates a defect in the primary hemostasis. So we have to think whether we need to give the antifibrinolytic alone for the mild bleed, or we need to consider the platelet transfusions for the significant bleeding. If child is presenting with deep bleed, muscle and joint bleed, in addition to that, there is a possibility of the underlying clotting proteins deficiencies. So we need to consider the clotting factor replacement. And broad management principles, always we need to avoid the education of the families to early recognition of the signs and symptoms of the bleeding is important. Need to avoid contact sports. We need to encourage the activities like cycling and then swimming. Avoid unnecessary IM injections. In case if they are needing, need to use the smallest gauge needle as possible. That is, and even after giving the injections, need to give the prolonged compression. And based on the underlying problems, we need to replace them with the platelet transfusions or the clotting factor. In case if we have not access to the clotting factor concentrates, need to give them the fresh frozen plasma or the cryoprecipitate, whichever is available immediately to save their life. Once we arrange the factor, next we have to consider the clotting factor administration. And with regard to the factor 8, factor 9 and von Willebrand factor administrations, it's always given as a slow IV bolus over 15 to 20 minutes. Always bring the vial to the room temperature and mix it by gently rolling the vials. Do not overshake the vials, and then administer as a slow IV push over the 20 minutes. In case if there is life-threatening bleeds, if it do not, there is another possibility. Is the recombinant factor 7 we can have in our hand. Always we need to have the multidisciplinary management, because hemophilia they can present with joint bleed. So we need the orthopedic corrections periodically, and sometimes they can present with intracranial bleed. We need the involvement of the neurologist and neurosurgeons for the management. So always multidisciplinary team management is important. Thank you. We thank PHO team for giving us the opportunity. So I had in chat box is unable to see the slides where slides were moving, Shivani.
Yes, your slides were moving.
If any questions are there. If there is no questions, we will just do the recap for each and every bleeding disorders. Commonest bleeding disorders or hemophilia. Commonest bleeding disorders or the hemophilia, they can present with commonly with the joint bleed. If the child is coming with joint bleed, first we need to reassure. Sister, I want to சொல்லுங்க அந்த குழந்தை. First, we need to rest and then protect the injured limb, and then need to immobilize the limb. Next is the administration, keeping the cold compression, then the limb elevation, then administration of the factor concentrate as early as possible. If it is not available, we have fresh frozen plasma and then cryoprecipitate. Cryoprecipitate has a more factor 8 concentrations compared to the fresh frozen plasma. So we need to administer the factor concentrate is not available. It's a cryoprecipitate. Then we can consider administering the factor concentrate once it's available. If the child is coming with intracranial bleeds, its involvement of the neurologist, neurosurgeon is important. As early as possible, we need to maintain the clotting factor concentrate at a dose of 100%. Need to consider 50 to 100 units per kg for initial 7 days, followed by another 7 days. Total of 14 days, we need to maintain the clotting factor concentrate. And then another common features which we come across, once immediately falling off the tooth, the child can come to the ER with the mucosal bleed. If the child is coming to the ER with the mucosal bleed, initials, or they can present with the bleeding from the nose. So if there is a skin and mucosa bleed in the child with underlying hemophilia, one is another. We need to consider controlling the bleeding at the local site. If the local site is compression with the gauze, we can add this tranexamic acid injections in the gauze and then consider the local compression. Second is parenteral tranexamic acid we can consider, and based on the severity of the bleed, if it's mild to moderate, only with local compressions or along with tranexamic acid, it may settle. If the bleeding is persistent to have, then we have to administer the concentrate or the cryo, whichever is available. Same problem we can come across in the child with von Willebrand disease. They can also present with skin and mucosal bleed or menorrhagia. Here, when we are considering about the replacement of the blood products, apart from the local control with the compression and the antifibrinolytic agent, when we are considering the factor concentrate, that the combination of the factor 8 and then von Willebrand concentrates are available. So we have to consider choose the factor which has both combination of the factor 8 and von Willebrand. If this is not available, cryoprecipitate has both factor 8 as well as the von Willebrand factor. So we have to consider replacing this. If child with chronic thrombocytopenia or if child with platelet dysfunction is coming with skin and mucosal bleed, here again is the control of mucosal bleeding with the local compression as well as by the antifibrinolytic agent. Next step is if they have significant bleeding, need to consider platelet transfusions. In platelet dysfunctions, even if the platelet number is normal, we have to consider the platelet transfusions in order to achieve the hemostasis. When we are discussing about the platelet transfusions, in case of thrombocytopenia in leukemic children who are going to need transplant, or in case of chronic thrombocytopenia due to the underlying marrow failure syndromes, whoever is going to need repeated transfusions, or in case of platelet dysfunctions, who is going to need repeated platelet transfusions, there is possibility of developing the alloimmunization. So when we come to, so we have to consider when we are choosing the platelet, whether to random donor platelet or single donor platelet. In child who is going to require long-term transfusion, it's better to consider the single donor platelet because that will reduce the donor exposure. In random donor platelets, what will happen in one bag itself, they'll pull from the 2 or 3 donors, platelets are pulled in the one bag. In single donor platelets, it's collected from the one particular donor. So the donor exposures will be low. So when we are considering the platelet transfusions, always prefer the single donor platelet. In a small children need to transfuse at a dose of 10 to 15 ml per kg. In older patients, less than 30 kg is a half unit and more than 30 kg, 1 unit. Among the blood products, PRBC, platelets, and then FFP, this plasma product and platelet can have significant transfusion associated reactions. So whenever we are transfusing, though it's rare, we always need to carefully monitor for the transfusion reactions. One is mainly the four major reactions are hemolytic reactions. Watch for the hemoglobinuria. Second is bacterial contamination of the product, fever, chills, rigors, hypertension. Third major is the transfusion associated lung injury. They can present like ARDS sort of picture. It's a sudden respiratory distress can happen. And next is the anaphylactic reaction. They can present with bronchospasms, stridor. So all of you need to know to recognize these four major transfusions reactions and need to act accordingly. Whenever the major transfusions reaction is happen, immediately need to stop the infusions and keep the IV line open with the normal saline, because most of them will have hypotension. Normal saline need to send the both child bloods, both EDTA sample, plain sample, as well as the urine sample and blood bag to the blood bank to monitor for, to evaluate for the transfusion transmitted reaction, whether there is a bacterial contamination or mismatch in the blood group is issued. This we need to always do. After stopping the infusions, after reporting it, need to always identify the child symptoms. Accordingly, we need to manage. In case of anaphylactic reactions, need to give adrenaline as well as the corticosteroids. Need to look for the bronchospasm, stridor. If there is a hemoglobinuria or the coagulopathy, we need to address it accordingly with the plasma and then platelet products. In case if there is a transfusions associated lung injury, we need to give the respiratory support accordingly. So always need to always learn to recognize what are the four major transfusions reactions. Also monitor for the other rare side effects, which is a volume overload, hypothermia because of the cold product transfusions. Hypothermia usually happens in the small infants, and electrolyte imbalances can happen, which is hyperkalemia is one of the life-threatening, which is a long-term storage product can also induces a hyperkalemia. So more four major transfusions reactions: hyperkalemia, hypothermia, and then volume overload. These are the signs transfusions related complications we need to recognize. Then coming to the family education, all the families, we need to give them the leaflet. What are the precautions they need to follow them while they are handling the child with bleeding disorder? For example, if they have the small babies at home, is avoid putting them in the cot, so making them lying down in the cot, and not to put it in the cradle unattended. Always baby needs to be in their supervision. When the child start to crawl, advise them to wear the knee pad, and if there is any sharp edges in the table, they have to cover it with the soft sponges. So that routine precautions we have to advise them. And how to identify for the early warning signs. In case of any smaller kids, it will be very difficult for them to identify the signs and symptoms, because smaller kids won't be able to tell. Once a child grows, eventually they will learn to identify if there is a small symptoms, like if they develop pain or pinching sensations. Based on that will be smaller kids only will have a crying sensation. So family, we need to educate them to identify the what are the early signs of bleeding manifestation. Next, what are all the precautions when they are growing? So avoid the contact sports, avoid unnecessary IM injections, avoid tablets like NSAIDs, ibugesics, which will lead on to the increase in the bleeding manifestation. And always educate them to have a concentrate, at least one or two factor concentrate with them, because in the midnight, if they land up with the emergencies, may not be available in all the pharmacies. If they have already in hand with them the factor concentrate, we can administer, and for the doses we can arrange accordingly. And always we need to have a periodic follow-up every year along with the multidisciplinary management. If any queries, you can add up and put it in the chat box.
Thank you, Dr. Meena and the team.
It was very comprehensive, actually, and you've covered almost every point that we should know about the children with bleeding disorders. Uh, any questions or discussions? I don't see any questions in the chat box as it is. If there is any question, please post on the chat box. Yeah, someone is trying to ask a question.
I don't know, fewer questions
Mr.
of slides
Pankaj,
are not visible, or I don't know whether they will be able to hear us properly.
okay.
Hello, ma'am, my
Voice
voice is clear.
problem. Voice
Hello.
Yeah,
problem. Ah, yes, yes.
yeah, Mr.
Hello.
Pankaj.
Ma'am, we
Yeah,
are
Pankaj.
facing some
Yeah.
problems like sometimes patients' blood volume are like we need 50 ml blood, but our blood bag amount is 100 and sometime 150. So so our doctor say like you can give through syringe.
Yes,
So
yes.
it is right or not?
Yes, we can give. But whenever you're taking it from the blood bag, you have to administer the blood set. From the blood set, you can attach the three-way and take your 15 because blood needs to come through the blood set because some of the time the micro aggregates will be there. So from blood bag directly you cannot take it in the syringe. Attach the blood set. In the blood set, you can attach the three-way. Then you can, because very small in neonates, it's administered
Yes.
through the syringe. So always it needs to be through the transfusion step. Then you can take it in the syringe and can give over the required amount and duration.
Yes. Okay. Thank you.
Yeah, Mr. Ashish has asked, can we use injection vitamin K as prophylaxis? Meena, you
Not,
want to take it?
it's vitamin K as a prophylaxis is not for all. If newborn, there is hemorrhagic diseases of the newborn, it's one of the commonest cause. So we can consider vitamin K and liver disease. Again, it's vitamin K dependent clotting proteins will be low. So that and in sepsis and child, if we are on prolonged antibiotic therapy and malabsorptions. So what would be the underlying cause? If you are suspecting vitamin K deficiency, in those kids, we can consider vitamin K prophylaxis, not routinely. All these bleeding disorders is a genetic problem. They are deficient to have produce this clotting factor. So 8, 9 on in the von Willebrand deficiencies. Here, vitamin K prophylaxis won't work. If they have liver disease, so weekly vitamin K. If they have any malabsorption, again, it's vitamin K prophylaxis would help. Hemorrhagic diseases of newborn. So there, vitamin K would work. So if they are on prolonged antibiotic therapy, vitamin K we can consider. So vitamin K, based on the underlying problem, we have to give.
Thank you, Meena. Any more questions? So,
In factor 8 deficiencies or whether we are opting for prophylaxis, it's based on the family and then physician discretions. It's based on whether we are opting for factor 8 prophylaxis or there is a newer injections called emicizumab, which they are opting for. Those prophylaxis is based on the family as well as the physician consent.
thank you, Meena. So, they've brought out all the points very comprehensively. Thank you to the team from Kanchi Kamakoti Child Trust Hospital for elucidating the approach and management of children with bleeding disorders. Simple points like we should be also knowing that the child is prone for bleeding. So that has to be educated at multiple levels. So the mother of the child, the attender who's coming, accompanying, or sometimes when the child comes in a sick state, what happens in emergency or PICU when they come off duty hours is that they go through all the invasive procedures at once. I mean, the point that they have a bleeding disorder sometimes may not be highlighted. So the parents have to be educated that this has to be highlighted to the treating team whenever they go for an unusual concern. For example, we have come across a child who had come in an emergency for dengue related illness. So dengue was the concern, and the child went through multiple lines and catheterized also. The underlying diagnosis of afibrinogenemia was not brought out, was not highlighted at that point of time because the child was not on regular prophylaxis or regular follow up. So that point, so like we have a card for the diabetes. So this underlying genetic diagnosis can be written in a card, one page card can be given to the parents so that they show it to the treating team whenever they go for some unrelated concerns. So if there are no further points, so there's one more comment. The absence of a blood warmer, how can we safely transfuse cold blood from the blood bank? Meena,
Can keep
do we regularly warm the blood?
no need to regularly warm the blood. It's a hypothermia only in extremely preterm or the neonates, only the small infants, malnourished, those in those kids alone it's concern. In other older children, it's regularly to keep the blood warm is not a concern. So we can keep it outside for 15 to 20 minutes and then we can start. As soon as removing from the temperature, we have to complete the infusions within 4 hours. Because the longer the time you keep in the room temperature, there is a risk of bacterial contaminations and then septic shock in the child. So we have to complete the infusions, need not to be warm. Only in the preterm or the younger infants, we have those concerns.
Yeah.
So we need to wrap it in a room temperature for some time and we can give it.
Agree, Meena. Thank you.
Thank you. Thank you.
So thank you everyone once again. So if there are no more queries, I'll then hand over the session back to ECO organizers. Himanshi, please take over. Thank you.
Thank you so much, ma'am. I'll end the session now. Thank you.
Thank you, ma'am.